Today we'll see this video in which we'll see what happens when due to a faulty drip set surge occurs during phacoemulsification. So this is one patient who presented with something like grade 4 to 5 nucleus. This is the fundus photograph which shows there's hardly any view and there's dense cataract, although on indirect ophthalmoscopy the fundus was normal. And this is the other eye which was pseudophakic, showing some amount of peripheral anterior capsular opacity and some amount of phimosis. This was the fundus which showed a splinter hemorrhage away from the disc and a suspicious cup, although the IOP was very much normal. So we proceeded for the phacoemulsification surgery for this eye, which was planned for cataract surgery and IOL implantation because of visually significant cataract. And after instilling intracameral lignocaine and viscoelastic, we proceeded for capsulorhexis. So in these kind of cataracts, the capsulorhexis is usually not an issue, as I have numerous times repeatedly demonstrated this in videos, because these capsules are not elastic. Proceeding for making a side port and then proceeding for hydrodissection to separate the cortex and nucleus from the overlying capsule. So till now the surgery is going with as routine and as planned. There's some amount of pupillary fluctuation, but it is expected. Now the moment we go for horizontal chop, we'll see that once the phaco tip has been buried and the chop has been conducted, when the phaco tip releases the nucleus segment, the pupil getting small, the chamber collapsing, and then immediately it regains. Now this is what is described as surge, outflow which outmatches and is much higher than the inflow because of the negative pressure in the aspiration line. So we can see that in slow motion, and this occurred repeatedly, and this was not something which I used to experience with the machine which I was using. So we can see it again happening once the phaco chop has been conducted, and this is a dangerous situation. So what I did was I assumed that this is probably a bad day, something which is not accounted for, and I switched to a lower vacuum setting and I started doing the surgery as usual. But then at some point of time, one of my staff members who had actually seen such a situation earlier when we had made a similar video where there was a kink in the IV line and this was causing a surge. So he decided to check the tubing, and when he was checking the tubing, he found that this time the kink was at another point. So he asked me that he will change the tubing, and so I stopped the surgery. And by inspecting the tubing, we can see that this time at the distal end of the tubing where it is being connected to the phaco tubing, there's a kink here which is causing limitation in the inflow. So I am waiting here. This is fast forwarded portion, and here I am waiting for the tubing to be replaced by a fresh IV line with no faults. So once that has been done, we proceeded to emulsify the pieces which were already dismantled during the earlier portion of the surgery, and we will simply see that this surgery is completed now. Although this patient had some amount of senile meiosis also, so the pupil didn't dilate very well, and during this exercise where the surge was occurring and the chamber was getting collapsed, this pupil started fatiguing out. So as the surgery proceeded, the pupil size became progressively smaller and smaller, although that was not a concern because it was still reasonable enough for me to conduct the surgery. At some point there was iris being caught in the phaco tip, but it was released immediately, and we have now proceeded to removing of the cortical matter. Now I would like to mention here is that it's very important, by judging by this particular incident, that the staff should be well trained, because surgeon when he is operating, he will have more or less a greater concentration on the proceedings inside the eye and what all is around in the OT, and any faulty instrument or fault occurring in the OT is usually cannot be appreciated by the surgeon. So a well-trained staff is an asset who will able to pinpoint mistakes and more importantly take care that these mistakes don't occur. So it's very important to examine the IV line or any other consumable which is used, because apart from the consumables like knife, chopper, phaco handpiece, the IV line is something which is not in front of the surgeon. So the staff has to take care of these things. This is the picture the next day. There's some amount of keratitis, although the patient's vision was 6/18 and gradually it recovered in a week to 6/9. Thank you.